So good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. So I thank all of you who are listening today. Thank you for tuning in. It means a lot to me because not so much for me, because I want you guys to hear the people that I bring on the show. And I bring a lot of amazing people. I have to say, day after day, week after week, you're hearing some amazing individuals. And today, by the way, if you like what you hear, please pass it on to your friends and your family. We are building an audience, thankfully, and more people are tuning into this podcast, which means a lot to me as well. But I want people to hear what the people I bring on have to say. So thank you for doing that as well. So today, it is such a pleasure to welcome to the Hamilton Review, David Bonda. David Bonda is a newly minted, maybe not newly minted, but he's new to Los Angeles. He is a pediatric neurosurgeon. He's has landed at the Guerin Center, which is at Cedars-Sinai Hospital. We're going to talk about the Guerin Center a little bit later on in this program. But he is an assistant professor over there. And Dr. David Bonda, welcome to the Hamilton Review.
Thank you. I appreciate you having me. This is great. Absolutely.
So I always begin with my guests by having them talk about themselves and a little bit about your background, where you grew up. And the big question I'd like to ask is, why did you become a pediatric neurosurgeon? I want to say that a couple of days ago, I had this delightful little charming 8-year-old girl walk in, very, very articulate, I have to say. And she looked at me and then she said, I love the human body, Dr. Bob. I go, really? She goes, I read about it all the time. I go, really? That's wonderful. And she goes, I want to be a doctor. I go, wow. Well, you're gonna if you're already 8 and you're reading about the human body, you're gonna be a good doctor. And she said, I want to be a neurosurgeon. I go, wow. And she didn't say brain surgeon.
A neurosurgeon.
Neurosurgeon. She said it very clearly. I want to be a neurosurgeon. And go, whoa, okay. Well, listen, my hat's off to you. But David Bonda, did you say that when you were 8 years of age?
No, I knew I loved science. I knew I loved neuroscience through high school. I had no idea what a neurosurgeon even was until I went to medical school, really. So that's great. Hats off to her. I'd love to meet her. She sounds amazing.
Well, I may arrange that. But
Please, I would love that.
Tell us your story. Where did you grow up, and how did you find yourself in the pediatric neurosurgery venue?
So I was born in New York, but I actually grew up in Cleveland. So I consider myself a Clevelander and Midwesterner in that way. I went to college in Philadelphia, University of Pennsylvania. I actually went there because I had this interest in neuroscience. So I had always really been fascinated by the brain. And after college, I was not quite sure what I wanted to do. I thought maybe a career in medicine, but I really did like neuroscience, and I was considering a PhD in neuroscience. So I went back to Cleveland. I worked at the institution there that became the place I went to medical school, which was Case Western Reserve University. And I did Alzheimer's disease research in the neuroscience lab. And I enjoyed it, but I kind of figured out over time that I think I would like medicine because of the more social and impactful direct patient care kind of aspects of it. And so I went to Case for medical school, and knowing I was neuroscience driven, I went in thinking either neurology, psychiatry, or neurosurgery. And I really had no idea what neurosurgery even did or was. And so I kind of went out of my way to shadow and experience each of those fields. And it was pretty quick in my first year that I fell in love with neurosurgery. It's extremely exciting, really fast paced, interesting. You have this incredible opportunity to work with patients at some of the most vulnerable times of their lives and impact them in unbelievable ways. And so I just really fixated on neurosurgery then. So that's what led me to neurosurgery. And then I did my residency in New York at a program called Donald and Barbara Zucker School of Medicine at Hofstra. Hofstra and Northwell. Northwell Health is a very large health system in New York, and they have hospitals on Long Island and Manhattan. Actually, the hospital Lenox Hill is a hospital that we were affiliated with, and you may have seen Lenox Hill on Netflix. That I trained with them, and I was there for some of those filming of that program.
Wow. Okay.
Um, but anyway, within neurosurgery, there's a lot of really amazing stuff and fascinating and really challenging subspecialties. And it wasn't until I rotated on our at our children's hospital that I fell in love with pediatric neurosurgery. And it kind of tied a lot of things together that I love. Number one was I just really like kids. I love taking care of kids and interacting with them and their families and helping guide them through really challenging moments in their lives. That was really appealing and is really appealing. And then, I think pediatric populations have a much different set of pathology, as the things that affect kids are much different than what affects adults. And I find that more interesting, a lot of developmental and embryologic kind of things. And, that was very appealing to me. And then I also have a specific interest in epilepsy. And pediatric epilepsy is particularly interesting as far as what causes it, much different than in adults, and how we treat it and the surgical aspects of that. So all those things led me to epilepsy and pediatric neurosurgery. And I did my fellowship in pediatric neurosurgery in Seattle at Seattle Children's Hospital, where they have a fantastic, very high volume center and a very large epilepsy practice. So that's where I did that training. And then I was able to get a great opportunity in LA.
Yeah. And by the way, welcome to LA. You have kind of traveled around. Finally, you did find the promised land here.
Yeah.
I hope. But I have to say, you say pediatrics, it's interesting when you're dealing with kids. First of all, they are delightful to deal with, and you are dealing with in a very, very high intense moments, because surgery is intense initially, but when you talk about neurosurgery, we're talking about the brain, and there's nothing that will get people's attention more and cause great anxiety than you start talking about the brain. But it does the cool thing that kind of led me to pediatrics was the fact that when you make your contribution, whatever it may be, you change a lifetime. And that was always attractive to me. I found that if I could actually intervene in a life and really potentially give this individual, this child, better life span, or better living because of what I did, that to me was extremely attractive to me. And I'm sure that was part of your decision as well.
Absolutely. And, you develop, another thing I love about medicine in general is you have this relationship with patients. And in neurosurgery, you actually have a very intimate relationship with your patients. And pediatric neurosurgery, even more so, and their families. And you will take care of them for years and years and years. And get that, similar to in primary care pediatrics, where you have a long-standing relationship with your patients, that I also have that opportunity and privilege in pediatric neurosurgery and impacting a child, potentially curing them from seizures or removing a brain tumor that would otherwise devastate them, and allowing them to live a completely normal life from then on out is quite a remarkable privilege.
Yeah. You are over at Cedars, and I want you to know that I did my pediatric rotation over at Cedars, and one of your past department chairs was a guy named Ben Kagan, who I'm sure you've heard that name. Mm-hmm. Dr. Ben Kagan was famous throughout the country, and I had a moment with Ben Kagan when I was trying to make my decision. And I said, Dr. Kagan, and he was an older man, very august and very, very professional. I went into his office and I kind of meekly sat there and I said, "Why did you become a pediatrician?" And he told me that. He said, basically, Bob, I went into it because I knew I could change an entire lifetime. And so I walked away and thought, you know what? That's what I want to do. I really, and so I want you to know that my pediatric direction was actually changed in exactly the location you're in right now over at Cedars-Sinai.
Great. That's very cool.
We're going to talk about epilepsy surgery, because this is very important to me, and also about the Guerin Center. But I want to, before we get into that, I do want to address a couple of issues which are common consultations that you guys get over in your department over there in neurosurgery. One of them is plagiocephaly. Plagiocephaly simply means, friends, it means a misshapen head. You see this all the time. Can you speak to this?
Absolutely. Plagiocephaly ends up often in my office or a neurosurgeon's office because while most of the time plagiocephaly is what we call positional, which means it's caused by the positioning of the child's head. There are cases where it's actually caused by something that we refer to as a premature fusion of cranial sutures. And so I can explain that. I actually have a skull model over there that probably will help, but I don't know if this is a video recorded, but
it's mainly audio, so you're going to have to do your
okay.
best to verbalize it. But it
No,
is.
no.
By the way, friends, this podcast is available on YouTube if you want to watch Dr. David. He's a real good-looking guy. But anyway, go ahead.
Thank you, for sure.
Go ahead.
I have a great face for radio, so they say. You know, the skull grows in a very specific way. It's directed by the brain's growth. The brain, you know, as it expands in volume, it creates these signals that allow or cause the skull to grow. And the skull has very specific patterns and parts along which it grows. And these are called the cranial sutures. They're like growth plates along the skull. And so you can have either syndromes or spontaneous and essentially random cases where a single suture line or multiple suture lines prematurely close. And what that means is the skull can no longer expand along that suture line. And it limits the skull's growth. And what you see in those cases is an abnormal head shape. That's usually the first thing that people notice. And when you have an abnormal head shape, you know, of a particular kind, that can be called plagiocephaly. There's also different, you know, the prefix for cephaly means head, describes what the deformity looks like. So plagio is flat head. Scaphocephaly is boat head, because patients with a particular craniosynostosis, which is what that is called, the premature fusion of the sutures, have an elongated head. It looks like a boat. And there's trigonocephaly. All these are terms that describe the head shape that looks abnormal because the suture is closed prematurely. And we see patients who come from someone like Dr. Bob, and they have what's called plagiocephaly. The vast majority of the time, it's positional. It's just the child has been putting too much weight or spending too much time with their head down on the ground, and it just kind of flattens out because the infant skull is malleable. And that's not a big deal, and often it can just be watched or corrected with helmeting. And that's, you know, it's mostly an aesthetic or cosmetic kind of thing. But, you know, the reason we get sent these patients is we sometimes need to rule out or even treat what's called craniosynostosis, which is that premature fusion of those sutures, or a suture. And, you know, much less common that that's the case, but if it is, it can be treated, and we do surgery to do it, which sounds scary, but it's something that we can take patients and families through, explain all the details of it. Kids do really, really well with it. And it's important to do because the main risk of having a prematurely fused suture, besides the cosmesis, the shape of the head, is that the brain can't grow to the same extent that it would normally, or it does grow and it's under pressure because the skull doesn't accommodate it. And so that increase in the intracranial pressure might result in problems like really, really bad headaches, vomiting, or it could even cause vision impairment, blindness, or, you know, it can be fatal. Yeah. And these things we can avoid and we want to avoid. And so that's why we as neurosurgeons see these patients, we work them up, and we can tell if or when that is a problem and how to deal with it.
So I've had a couple of these kids that I've sent over to you guys, and basically what happens, friends, is they crack the bone, they open it up, and they essentially diffuse the impingement, I guess, or the constriction of the brain growth. And I'll tell you, some of these kids, I look at them today, and they have beautiful heads. I completely forget that they had any issue of all. I have to look on the chart to remind myself. Okay, that's topic number one. Topic number two is I have a lot of kids in my practice, boys and girls, who are out there doing a lot of sports. And I champion sports. I tell people kids should be outside all the time, you know, team sports, individual sports like tennis, whatever. But but they get whacked in the head all the time, or they fall down, or they trip, they fall off their bike. Concussions and head trauma is something that is I get a lot of phone calls about this. Okay. So David, can you just kind of walk us through quickly, what are the questions that you ask parents when they say, I think my kid had a concussion? And And also the big bad thing was what we're worried about is concussions are one thing, but intracranial bleeding is what people really are worried about. So can you walk us through that?
Yeah, of course. You know, any head trauma, first of all, head trauma is extremely common, especially in babies and toddlers who are running around without coordination, bump into things, or get dropped or what have you. It's extremely common, and the vast majority of the time, kids do totally fine. Concussions occur when you have a head trauma and the brain gets a certain amount of impact that causes some kind of an inflammatory process. And, most of the time, it's just something that gets better, but with time, and you just have to allow that time to unfold. But when someone mentions to me that their child has hit their head or there's some kind of an injury to the head, the things that I want to know boil down to how is the child behaving? Because the behavior of the child tells us more about how the brain is working than anything else, and even more than any imaging of the head or brain will tell you. And so the things that are important to kind of help triage or figure out the where to, what to do in these circumstances are how old is a child? Because if it's a tiny baby who's less than 3 months old, they have a much softer skull. They're much more susceptible to some kind of injury. And I don't know if, that's even your question, because when we're talking about sports and things like that, it's obviously not that population, but those kids should come to the hospital regardless, and we can assess them. Any older than that, you want to know, have they lost consciousness? If you lose consciousness from a head injury, that's a sign that it was a more severe head injury, and the duration of that consciousness loss is important. If it's more than 5 minutes, then definitely important to go to the hospital. Even if you've lost consciousness at all, you should go to the hospital. But if the kid has hit their head, they're playing sports, they don't lose consciousness, then what? The behavior and how they feel and are acting is a very good indicator of what's going on if there's something really concerning. And what I mean by that is in babies or kids who can't talk yet, what's their mental status like? Are they awake and alert? Are they interacting like they normally do, tracking and cooing? Are they behaving like themselves, or is something different? They're agitated, you can't console them. Are they really sleepy and you can't kind of rouse them? Are they not eating like they normally do? Are they vomiting? All those things are more worrisome. And if they are back to their baseline and behaving really well, that's very, very reassuring. No matter what an image on the head shows, almost.
Sure.
And so, that kind of guides our management in general. And so, when we're talking about adolescents or teenagers who are playing sports and might have a head injury, it's kind of a similar thing, except you can actually get more information from those kids. They can tell you, I'm feeling foggy, I'm having a headache, I'm a little confused, my memory isn't right, I'm a little out of it. Or you can ask them questions at the sidelines. Do a quick assessment, where are you, what's going on, do you remember what happened, and et cetera. In the short term following a concussion, it's quite normal to have abnormalities like a little bit of confusion or disorientation. And you should expect to see all of those things get better with time. And if they don't get better with time, if things are worsening, then you want to seek definitely urgent medical attention.
So time you're talking about, like say for a teenager who gets whacked in the head and they're a little foggy, they're kind of out of it for a short time. What is your general recommendations in terms of time away from the sport?
Yeah, there's a lot of guidelines out there to help with that kind of stuff. And essentially you definitely want, if they've had a concussion to the point where they're disoriented at the sidelines, you want to sit them out the rest of that game. Let them kind of, quote, recover. And they don't need necessarily to be completely stimulus free in a dark, quiet room, but just they can listen to how their body feels, just take it easy, go home, they can watch TV or read a book or, interact with their family normally, but they might be a little sensitive to light or have headaches. And, you have to follow those symptoms to figure out when they should return. I would say they should be completely back to normal with no residual signs or symptoms of that concussion before returning to play.
Yeah.
I would, if there are any residual headaches or brain fog or, sensitivity to light, I would continue to hold off before going fully back in and ramping that activity, as tolerated.
Yeah, that's kind of what we say. And I think that, there isn't, I think it's important that people know that there isn't an exact timing of this. There's a certain variability, kid to kid and patient to patient. You just have to realize that. We're becoming much more aware of concussions, and we try, in the old days, the coach would say, yeah, you took a stinger, or you got your head, you got your bell rung, and get back out there. And so, but now we do take it pretty seriously. Okay.
And actually, I'll add one thing, because it is really important. There is an issue that can happen if you just return to play immediately. If you have a concussion, and this actually is particular to children, the reasons are not entirely clear, but there's something called second impact syndrome, where if you have a concussion on the field, you go back to play and you suffer another head trauma in a very small subset of patients, but it does happen. For some reason, it precipitates a very severe increase in intracranial pressure and can be fatal very rapidly. And it's very uncommon. I've seen it, and it's something that can be prevented simply by not going back to play immediately in the setting of a concussion. We don't really know why it happens or in whom. You can't really predict or what exactly the mechanisms are, but for some reason, a second impact shortly after, within 30 minutes to a couple hours after first head trauma, can cause a very diffuse inflammatory process that causes the pressure inside the brain to really rise, a lot of swelling. And often those kids need emergency surgery to decompress and recover in the ICU. And it can be quite devastating.
Yeah. So friends, parents out there who are listening, that is good advice. So if your kid gets whacked in the head and they're a little foggy, take them out of play. I don't care what the coach says. I don't care what anyone says. I don't care if they're the best player on the team and need to make that 3-pointer from the line. You gotta pull them out. Okay. And how often does intracranial bleeding occur? It's pretty rare, right?
It's funny. Intracranial bleeding can scare people a lot. And the fact of the matter is, we actually see a small amount of blood product on top of the brain following an injury very commonly. And that is not necessarily worrisome. We see, anyone who hits their head and gets a CAT scan, which is definitely not all the people who hit their head. If we scanned every single person who bumped their head, we would see a good amount of little ditzels or patchy areas where a small amount of blood has kind of spilled out, just like anywhere else in your body. You get a little bit of a bruise or a scrape. And that in and of itself is not something that's ongoing or worrisome. Even kids that we see in the hospital, they have a head injury, they get a CAT scan of their head, and they have a tiny bit of blood inside the head. That doesn't change much as far as what we do, as long as the kid is okay. And that's why I say, the behavior and how the kid is feeling or acting neurologically tells us much more. And that's what guides our management. And so a kid who has a small amount of blood in the head after a fall or a head injury, if they're totally at their baseline, feeling fine, acting fine, which is totally possible and likely, then there's nothing to worry about, and that blood will go away with time. The bigger bleeds happen with more, high impact or high energy head strikes. That's much less common.
Yeah. And
if someone has something like that following a head injury, especially in a kid, you would know they would have horrible, severe headaches. They'd be lethargic or unable to be aroused. You'd be, vomiting, weakness on one side of their body, seizure, something like that's going on. Obviously, you want to take the child to the hospital. But in the absence of really those kind of things, as if the kid is behaving at their baseline, the likelihood that there's some really problematic bleed going on is very low. Now, an exception I'll say is the energy of the impact makes a difference. If it's a high velocity or high energy impact, you still want to come to the hospital, because there can be what's called lucid intervals where, there is some bleed in a particular space that the brain can accommodate for some period of time before it gets big enough to cause really rapid neurologic problems.
Yeah.
And if there's a direct head strike with some bat or, something really severe, or a car accident where people are ejected or airbags go off and a head is hit, you want to go to the hospital anyway.
Yeah. No, I mean, I think that, skiing injuries, skateboard injuries, things where the kids fall off of a building or something like that, those are significant. And fortunately, thank God, they're rare. Okay,
Yes.
I want to talk about something else rare, and I want to kind of approach it gingerly. But another worry that we have, and you know this, Dr. Bonda, is that brain tumors, those two words terrify people, including me. And the reality is, in your world, the world that you deal with, you see that. And I rarely see it, but I have seen it. Tell us a little bit about, so there are a lot of people who, see something funny in their kid and they think, oh my gosh, my baby, and they can't sleep all night because they think that they have something going on.
Mm-hmm.
Tell us maybe in your, just how you would assess, what are the red flags that there may be something brewing, and the things that we should, they should zip over to you for.
Yeah. So, the most common ways that brain tumors present in children has to do with the mass effect, or the occupying space occupied by the tumor, and how it changes what's going on in the brain. And so either that will cause a problem related to the pressure inside the head, which has very characteristic symptoms, or direct effect on part of the brain, which can have very specific set of symptoms. So what I mean by that is, the most common way that kids present is with something called hydrocephalus. What that is, all of us have these fluid compartments that are deep within our brain that make spinal fluid, and spinal fluid is constantly being made. And we make about a half liter a day of it, and it drains like plumbing and circulates our brain and spine. If there's something that blocks that flow of fluid, and it can't take that normal pathway and get reabsorbed and circulate, that fluid keeps getting made and it builds up, and that increases the pressure in the head. That's called hydrocephalus. The most common location for tumors in children happen to be in a place where it blocks that flow of spinal fluid and causes the fluid to build up. And that takes time. This usually, in the vast majority of cases, it's a very slow process. And so what you might see are symptoms of a slowly increasing intracranial pressure rise. And that translates to kids are having headaches, and those headaches are worse right when they wake up in the morning or in the middle of the night, headaches that might wake them up in the middle of the night. So that's always something I ask. Vision. Are they getting blurry vision? Is their vision starting to worsen, and they've started needing glasses, or they have glasses, but they're still seeing blurry vision or double vision? Again, this is related to the pressure increase in the head that's the result of that fluid buildup. Vomiting, spontaneous projectile vomiting, similar cause. And another thing is lethargy. So if the child is just all of a sudden over the last day or two just very sleepy, unable to be roused, wants to nap more than usual, is fatigued. These are all symptoms often of a problem with the pressure inside the head.
So those, those are the things that we're looking for. Certainly when we get on the telephone, we're asking, are you waking up in the middle of the night with a headache? If that happens, that to me is a big clue that we need to look at that kiddo. Certainly lethargy. Certainly just that, blurred or double vision is a big red flag. So listen, friends, thankfully, the vast majority of kids, brain tumors are rare. And so our anxieties are usually unfounded, or they're not, and nothing bad's going on. But I think it's important that you call us as pediatricians initially, and then obviously we make a referral to the right people, including people like Dr. Bonda. David, I'm watching our time here. I want to talk about your specialty, and you have an expertise in epilepsy surgery. Epilepsy is, of course, seizure activity, and more you're able to actually deal with it and surgically basically take it out, right? And tell us a little bit about maybe a little bit of the history of this and where you're at with that, because this is really a very, very positive step in terms of those people who have epilepsy, and some people have really intractable epilepsy. So if you can speak to that.
Of course. So yeah, I mean, like you said, epilepsy is a seizure disorder, and is specifically defined as having 2 or more unprovoked seizures over a period of time that is longer than a couple hours. And unprovoked just means, there's no immediate head injury that caused it. You're not actively having a fever, because children can get febrile seizures, or there's nothing like a brain tumor there, which also, by the way, is something that patients present with if they have a brain tumor, is a seizure. But if patients have seizure activity that's ongoing or happens repeatedly, they require a large workup to see what's going on. And there's a lot of different reasons brains can seize, especially in children. And most of those kids can be controlled on medication. And actually, it's about 2/3 of patients with epilepsy have control with medications, oral medications. But there's a third of patients, which is a lot of epilepsy patients, who are what we call drug resistant. And that means that they continue to have seizure activity despite having been on at least 2 anti-seizure medications. That is in those particular cases, which is a third of patients, they are candidates for surgical intervention. And even though it sounds really scary, or it sounds and often used to be thought of as a last resort for treatment of epilepsy, we have found over the last 10 years, really, it's become increasingly clear that the earlier you intervene surgically in patients who have drug-resistant epilepsy, the better their outcomes are. And that's because, as you would imagine, as the brain grows, it requires kind of normal activity to wire itself in a really normal way, to be able to learn how to learn, so that the child can get their language function and their fine motor skills, and, et cetera, et cetera. And if seizures are happening and constantly just interrupting that process, you get abnormal development or severely impaired development.
Yeah.
And, the fact of the matter is that if you can stop those seizures, however you can stop them, you can dramatically improve the developmental trajectory of the child, including their intellectual development and their cognitive development, as well as their quality of life. The proportion of patients with epilepsy who have mood disorders like depression or anxiety is far greater than the general population. And epilepsy is also a fatal disease. It's the life expectancy of patients with epilepsy is shorter, much shorter than those without, and that's because epilepsy can produce death. And so for all those reasons, we actually try to intervene surgically when necessary, as early as possible. And we have a multidisciplinary team at Guerin Children's here, and Debbie Holder is our pediatric epileptologist, who's fantastic. She's a neurologist that specializes in epilepsy. Jeff Swartz, another one of our epileptologists, myself. And we essentially see these kids together, decide if they could benefit from surgery, and then we discuss with the family what that means and what that entails.
So you're looking at the brain, you do scans, you're evaluating with the EEGs, electroencephalograms, and you're basically pinpointing where the seizure activity is emanating from. That's what do you actually cut it out, or do you zap it? What is the mechanism of your amelioration?
So we basically, yes, we do this large workup to figure out, can we figure out where the seizures are coming from? In a subset of those patients, yes, we can. And that's called lesional epilepsy. Those are kids who have an identifiable focus that we believe is causing their seizures. Those kids, we find that either on imaging or a combination of imaging and EEG and how their seizures present. Those kids, we can actually go in and either resect, we'll take out the tissue that's responsible and remove it, or we can actually do less invasive, and sometimes it's an appropriate way to ablate it using a laser fiber. We implant a very fine fiber into the area, and we could thermally injure the tissue to destroy what's causing the seizure. So that's the lesional epilepsy, and we attempt to cure patients who have epilepsy from a defined lesion. And the cure rates in the literature and across the country hover at around 65-70% at about 10 years. So it's not perfect, but in the vast majority of these patients, we can cure their epilepsy by taking out a piece. And it sounds really scary, and sounds like, well, you're taking out brain, but the fact of the matter is, hey, the region that's causing the epilepsy is not normally functional. It's not something that's helping the child, it's not doing anything positive. It's only causing seizures. And B, the seizures themselves dramatically disrupt the brain. And so by taking that out and alleviating the brain of that seizure focus, you really, really improve things.
So you're talking about these are people who do not take medications any longer. They're cured in the sense that they're done medications, or are these people, some of them take medications, some of them not? How does that work?
So it depends. Sometimes they're on medication still, but they lower the dose. We can lower the doses pretty significantly, and sometimes we can get them off of medication. And that is a really strong advantage because a lot of these medications have significant side effects. But when we talk about the biggest important thing is to stop the actual seizures, and then secondarily, we always try to wean them off the medication.
Sure.
But there's another population of patients who are not as fortunate and don't have a defined focus that's causing their seizures. Either they have a genetic condition where the sodium channels, for example, all throughout their brain are dysfunctional and just cause diffuse seizure onset, or there's multiple foci and multiple places are causing seizure. You can't cure those patients with a resective surgery. And so for the longest time, there were very few options for those patients. They would just be devastated by ongoing diffuse seizure activity. And despite however many medications you throw at them, they just become debilitated and require around-the-clock care and are extremely intellectually impaired. Recently, not recently being now 30 years ago, I suppose, neuromodulation, it became a resource. And what that is we're delivering electric current to some aspect of the nervous system in an attempt to reduce the seizure frequency. And 30 years ago, the device called a vagus nerve stimulator was FDA approved. Actually, it was approved in 1997, so almost 30 years ago. And that's a device we implant into a cranial nerve in the neck that strongly connects throughout the brain with the brain. And we actually can wrap this little electrode around the vagus nerve, and we implant a little pulse generator into their chest wall under the skin, and it just delivers stimulus, electric current to the nerve throughout the day and reduces seizure frequency by 50 to 60% in most patients.
Wow, that's amazing. By the way,
go ahead.
Yeah, no, that to me is especially these with diffuse brain injury or brain issues, foci. Then this is an amazing breakthrough. By the way, this is just parenthetically me interested. When you actually get in there and you actually look at the tissue, which is causing the seizure to occur to these people who have the focal points, does the tissue look different?
It feels different. Most of the time, seizure causing tissue is very firm and gliotic. It's like scar. It definitely feels much different than the surrounding normal brain. And so we actually go in the operating room. Of course, we're operating under a microscope and, using a lot of different techniques, but often and predominantly we are using feel. We can tell just by the feel of the tissue where it is abnormal. Yeah. And that helps guide our resections in those cases, actually.
Fascinating. Okay, we're winding down here. I do want to talk one last thing about the Guerin Center, because this to me is an extremely exciting development in Los Angeles. And I'll let you kind of present what's going on over at Cedars-Sinai.
Yes. Let me give one more plug for the epilepsy thing, because I mentioned the neuromodulation. Yeah. Which vagal nerve stimulation or vagus nerve stimulation is only the beginning. And we have these technologies now where we implant electrodes into the brain that have much, much more superior seizure freedom outcomes or seizure control outcomes. And things like deep brain stimulation or responsive neurostimulation that we do here at Guerin's and are done at many centers around the country, where we can reduce seizure frequency in some of these kids with genetic epilepsies or other kinds by up to 70, 80%. And so that is a massive change in their lives and their families' lives. So I just, to finish that neuromodulation discussion, I just want people to know that it is very much available, and we are, actively doing that stuff. But
that is amazing. By the way, friends, I hope everyone out there listening, are appreciating the incredible advancements that have happened in Western medicine over the last 20, 30 years, last century for sure. It is truly, truly a different world that we live in. And I honestly, David, I am thankful for it every day. Honestly, I think about, I think
Great.
about what happened 100 years ago, labor and delivery, things that happened, so many blessings that we enjoy in our world today. Okay,
Absolutely.
Guerin Center, take it away.
Yeah, so Guerin Children is this beautiful brand new children's institute within Cedars-Sinai. It opened a year and a half ago, I think, and we have a huge team dedicated to pediatric care here. And not only do we have pediatric neurosurgeons, we have pediatric cardiac surgeons, orthopedic surgeons, all the subspecialists you could think of. All the auxiliary staff and people important for all the things that we do, pediatric nursing and phlebotomy, child life, anesthesia, everything that's needed for comprehensive pediatric care that you would expect to get at any freestanding children's hospital we have here. And what we are really proud of is that we are growing and we are able to care for the huge number of patients who are born in the Cedars-Sinai health system and who otherwise used to have to seek subspecialty care elsewhere, but we can take care of these patients here, in addition to any other patient that need our services. And we have an amazing group of people. Everyone is really collegial and friendly and happy to talk with providers and families alike. And I'm very excited to be here and be a part of this growth.
I'm so thankful. Listen, I will tell you that we met. I met personally with several of the people over there at Guerin's recently, and what you're building over there is extremely exciting. I love your availability. I love the fact that you guys are starting something new and fresh, and this is an incredible resource to our families here in Los Angeles. We're fortunate people, those who live in LA and those who are who are listening to the show who live other places. You can come to LA if you want to for a while and be seen by phenomenal people. So good job over there. My best to you, everyone over at Guerin. Okay, we're going to finish with that. Dr. David Bonda, thank you so much for taking the time. I know you're a busy guy to be on the Hamilton Review. You've been very, very helpful, the topics we talked about. And friends, thank you for tuning in today. I appreciate you being here. And until next time, be well. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.